Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Sagg, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, January 24th, 2025, we are speaking with Dr. Melanie Thompson. Dr. Thompson is a clinical researcher and provider of HIV care in the Atlanta area. She maintains an HIV practice in Atlanta and has particular interest in the prevention and treatment of HIV infection. As a principal investigator and executive director of the AIDS Research Consortium of Atlanta, ARCA, she has led over 400 studies of HIV treatment and prevention and is recognized as an expert in the treatment of patients with HIV. Dr. Thompson co-chairs the HIV Medicine Association Infectious Disease Society of America HIV Primary Care Guidance Panel and serves on the IAS-USA Antiretroviral Therapy Guidelines Panel, which she chaired from 2009 to 2013. She also served on the HHS Antiretroviral Guidelines Panel. Today, Dr. Thompson joins us to talk about what's new in primary care of HIV. Melanie, welcome to the podcast.
Thanks so much, Mike. I'm excited to be here.
Well, it's great to have you. And maybe we'll start off just talking a little bit about the past. You got involved in HIV care way back in the 1980s, I believe, right after you finished your residency, and just dove right in and started taking care of patients when there really wasn't much we had to offer. Flashback for just a minute and tell us about that background. How did that start and what was it like?
Well, as you know very well, Mike, at the time when HIV was really out of control, at that time it was really AIDS because we had no drugs and people ultimately were diagnosed when they had AIDS. It was a very hard time. And as I was in my clinical years of medical school and then in a residency for internal medicine, I really was overwhelmed by the death and the lack of hope for people. We really did all we could, but it also became apparent to me that this was an area where social justice was very important. The stigma, the discrimination was really top of mind. It was a time when we had no government support and the government actually was ignoring the epidemic. So, that was a tough time. And I feel like that the fact that we saw so many people really drove me to focus on HIV when I got out of my residency program.
Right. And at that time, there was a mixture of individuals who provided HIV care. There were some hem-onc people like Paul Volberding and Ram Bitsiasu, but there were also a lot of ID docs. You were one of a handful of internists who dove in and you learned on the fly how to treat all the opportunistic infections and sort of got up to speed quickly. What did you think was an advantage of being an internist as opposed to a specialist?
Well, quite honestly, at that time, taking care of people with HIV was its own specialty, although not so recognized. HIV is an infection that involves all the organ systems. And at that time, I think we were seeing multi-organ involvement with not only opportunistic diseases, but other conditions. And so, I think that was an advantage, but I really think also that it was a time where everybody who could and would was jumping on the HIV bandwagon. So while I was sometimes an ID wannabe, I actually almost went into infectious diseases, but ended up in a practice where people were taking care of a lot of people with HIV. So, that I think being an internist was helpful at that time, as it is now.
Yeah, I was going to say that segueing over to the current time, Fortunately, we have remarkable therapies, and people who we never thought would make it past their age of birthday of 40 or 45 are now in their 60s, 70s, some of them in their 80s because of treatment. And with more than 85, 90% of patients in a lot of people's practice having suppressed virus, um, being an internist is a huge advantage right now because we spend a lot of our time in clinic taking care of people with all the other things that everyone sort of encounters: high blood pressure, lipids, problems with heart disease, and that type of thing. So that introduces us to a huge role that you've been playing for at least a couple decades in terms of helping HIV providers understand how to do primary care and the primary care guidelines. So those were just published just a few weeks, maybe a month or so ago. Tell us what's new. The top line things that you uh, saw coming out in this issue of the guidelines for primary care.
Well, one of the things that's different about this version of the guidance, which is an update from the 2020 version, is that we have created some new sections and we also have intensified our focus on some areas. For example, in terms of optimizing care, we're including coverage of telemedicine, street medicine, and so on. We have enlarged our sections, created new sections on sexually transmitted infections, diagnosis, treatment, and prevention now, with a focus on doxypep. We also have a new section intensifying our interest in cancer screening and prevention, particularly anal cancer. As we know, people with HIV now are dying of cancer at a higher rate than of AIDS. So we included those. We also have a new section on vaccinations, specifically for people with HIV. And of course, that changes all the time, but we have updated information, particularly on the hepatitis vaccines and a recommendation for preferred hepatitis vaccine, Heplisav, for people with HIV, a 2-dose vaccine. And then we also have an expanded metabolic section, and we focus on the use of statins for people with HIV. We can get into that a little more, and based on the Reprieve study. And we also have added a section on children, which we never had before, but felt a need to provide some guidance for people taking care of children with HIV. We also have a section on adolescents and an important section on people who are transgender or gender diverse. And that is increasingly important. And we can talk about that a little more as well. And then finally, a bit more about COVID. So I think there's some very important updates in this version of the guidance, which, by the way, is available free online through Clinical Infectious Diseases Journal.
That's awesome. And what a wide array of topics just in one document. That's fantastic. Well, let's parse through some of this, and as much as we have time for. Uh, I want to talk. We've had other podcasts on statin therapy. We've had it on the GLP-1 agonists, and I'll refer listeners to those episodes rather than digging deep into those. A couple things you said that we haven't covered yet on any of the podcasts, and I may start with this: that you mentioned right out the front that outreach, street clinics, telemedicine. Let's go into that a little bit. What's new in those areas?
Well, I think when we last updated this guidance, we were really in the middle of the pandemic, and we learned a lot during that time about telemedicine. And for many of us, telemedicine became the primary way that we interacted with our patients for a period of time. And while we had to do it at that time. Now I think people are finding that this is a very useful modality to reach some people with HIV. It's not great for everybody, and it's not meant to be the only way we interact with people. But we do have data that supports using telemedicine uh, as a way to engage and keep people or help people stay in care and help them maintain their viral suppression. So I think that is really important. The other modality that we mention is really taking care of people where they are. As you know, so many people with HIV are experiencing unstable housing, and those people are very high risk for death. So reaching out to people through street medicine is a very important new emerging modality. It's not every clinic can do that, but in places where that is possible, this can be a really important way of delivering services and being sure that people have what they need to uh, stay on medicines, get medicines, stay on medicines, keep their virus suppressed, and engage in care. And the other thing I will say about the section on optimizing care is that we emphasize, I think more than ever before, the importance of creating an environment that people want to come to. So a clinic that is welcoming, that is culturally aware, that uses people first language, that identifies people by the appropriate pronouns and the appropriate name. And, I think this is more and more important because one of our real challenges is helping people stay in care once they make that first touch. If you look at the data, our so-called retention in care is really not good on a national basis. And when you talk to patients who are out of care, one thing you hear is they just don't feel comfortable in their clinics. They feel judged, they feel stigmatized. And this is particularly true for people who are transgender, gender diverse. It's true for people who speak languages other than English. It's true for people whose immigration status puts them at risk. And I have to say, in the current environment right now, these things are more important than ever. So that is a really important aspect of our guidance.
Yeah. A lot of people at I'd say most HIV clinics that I'm aware of, especially the Ryan White funded clinics, uh, find that their clinic is a bit of an oasis. They feel most people do feel comfortable coming into those clinics and feel like it's a haven where they can escape some of the other pressures of life. But for those people who are on the street, a lot of them have substance use disorder, as you mentioned, unstable housing. Um, we're struggling a little bit with how to do that. I guess the options might be to set up stand-up clinics in areas with a higher concentration of patients, make it a little bit easier for them to come in. And a large city like Atlanta, I suspect that's very important. But also mobile clinics where there's a van that might circulate. Um, Tell us a little bit more about that. Do y'all go into details of that or just mention it?
We provide some references. We don't go into the details of how to set up a mobile clinic, but there are important references. And I would say throughout the guidance, the references are very important and can point people to more detail on any of the areas that we cover. But I think, different strokes for different clinics. They're doing a lot of great work in Miami, for example, with mobile clinics, with street medicine, different ways to deliver care. So um, I think this is increasingly important. And you mentioned substance use and mental health. These are the very important areas of medicine that have always been sidelined by our traditional healthcare system. It's not really considered healthcare by many insurance companies. People who have insurance often have very limited coverage, if any, for mental health and substance use. So I think the more that clinics can incorporate these areas into their clinics for one-stop shopping. It's extremely important. And when that's not possible, making relationships with clinics that provide substance use and mental health care, being sure people have transportation, being sure that we offer some case management to help them get there. These are things that we can do because these are key reasons that many people struggle to stay in care and to stay on their medications.
Yeah, and as you're saying that, I'm thinking just in the big picture how, in a lot of ways, HIV medicine has really led the way for primary care for adults in a number of areas. Going back to the 80s and moving forward, the concept of a medical home, the concept of one-stop shopping so that patients don't have to bounce through a complex health system and minimizing that, having walk-in clinics, if you will, when people have a new illness that they want to get seen. And then, as you just mentioned, a more comprehensive approach to healthcare for substance use, mental health issues, all in one place if possible. And that I think is a real tribute to those who provide HIV care to so many people.
And also, Mike, hepatitis, viral hepatitis, is an area where Ryan White clinics and HIV clinicians have really led the way, incorporating screening, treatment, vaccination for hepatitis B, and cure for hepatitis C is something that HIV clinicians are really good at. And this also allows one-stop shopping when that can be incorporated into regular HIV care.
Yeah, it's awesome, and I agree with you. I would put the rates of hepatitis C cure from any primary care area uh, up against the HIV clinics because most HIV clinics have got a 95% rate of cure. They check and then they treat and move on, and it doesn't matter if even if they have ongoing active substance use disorders, they get treated and cured, and that helps reduce the community burden of those diseases. Um, Coming back to substance use, the other thing I think that we're really good at is providing Narcan, right,
Mm.
for people. And is that in the guidance and in the section on substance use disorder?
There are a number of recommendations about substance use disorder, and I do think it is important that every clinic have access to Narcan. Deaths from overdoses have declined
Mhm.
as we have become more aware and have provided more access to Narcan. And this is also important in syringe service programs, which often are treating people with HIV, but also people who are at risk for HIV. But even in, an average primary care practice or primary care clinic, it's important to recognize the risk of overdose and have Narcan on board.
Yeah, absolutely. And then buprenorphine for those who have opioid use disorders, trying to help them transition uh, from active drug use to something that they're in more control of and can actually reduce some of the financial burden of being in an addiction situation where they're having to score drugs every day or every other day to kind of stay functional. Um,
And we do recommend buprenorphine when appropriate, and this is something that any primary care provider can learn.
right.
It's not that hard, but it is that helpful, and so this is something that is really important to incorporate.
Yeah, and I'll just again reference for most of these topics there are detailed podcasts from Going Antiviral that go into great detail of how to use bup, how to use Narcan. You mentioned doxypep. That's something else where there is a large. There's a couple of detailed uh, podcast dedicated to that. Our time, as I knew it would, is moving pretty quickly, and you mentioned what we should be doing or what your recommendations are for advocacy. Maybe you can talk about that a little bit.
Well, as I mentioned, I got into this field when we had very little to offer patients, but also when it was really important to be engaged in advocacy, engaged in the fight for social justice. And I have to say, sadly, That has not gone away, and right now we are in a very tenuous position. And I would just encourage all clinicians to make use of all your skills, including your advocacy voice, because our job doesn't end in the exam room. And right now, the federal budget is coming back up for review. All of our Ryan White funding is at risk, funding for NIH, for CDC, for HRSA, for SAMHSA. And it's really important that we advocate with our representatives and our senators. Clinician voices are really still respected on the Hill, and people like to hear from us. So, if you don't know who your representative is, find out and approach them, call them, send them emails, set up meetings to meet them and provide resources for them. And I would also say, for those who are interested, HIV-MA, the HIV Medicine Association, is an important advocacy group, and they offer a lot of help with talking points, with targeting the kind of advocacy that is needed. And the other advocacy point that I would particularly like to emphasize right now is that as we go through this transition, we already are seeing increased risk to people who uh, uh, are transgender or gender diverse. We have to really reach out to those individuals. They're scared, uh, and to let them know that we have their backs, and to keep supporting them in all ways that we can, but also to fight back by opposing these measures in Congress and in state legislatures. And then equally, our individuals who are migrants here, whether documented or undocumented, are petrified right now.
Mm-hmm.
And that could keep people from coming to clinics. It could keep people from going to the emergency room when they're sick. And so I think a special outreach to those individuals to let them know they are welcome and they are safe in our clinics is really important. And also to fight back through our representatives at the national level, at the state level, to let them know that it's not okay to target people who are here from other countries in the United States, regardless of their status, when their health is concerned. So here we are in the fight for social justice, again, more than ever. So I just urge people not to get discouraged, to keep up the fight, because we've done this before. We've been here before, and we can prevail. It's not an easy or short road, but it's important.
And one of the things to make this even a broader appeal politically, there obviously might well be people watching or listening to the podcast who would say, well, that sounds like a liberal agenda about migrants. But from a medical standpoint, community viral load is critical. That means the overall number of people in the community who might have HIV, and if their virus isn't suppressed, there's a threat, obviously, to their health, but there's also an increased likelihood of transmission of HIV in the community. So keeping people in care is obviously very good for that individual, but it's also good for the public health and the community at large. If people's virus is suppressed, they won't be transmitting to anybody else, and that is important for all of us as well. So keeping people in care, regardless of their gender, regardless um, of their migrant status, legal or illegal, is really important for the public health as well. Let's finish with a return to primary care. And the next decade is going to be interesting because a lot of the original HIV providers, and I'm throwing you and me in that group, are aging. They're talking about aging in HIV, but this is also aging of providers. And we probably won't be practicing the way we are today in 15 years, let's say. So there has to be a new generation of providers. A lot of them are advanced practice providers who do an unbelievable job. But for physician providers, it feels to me like we should be looking at HIV medicine as a subset of internal medicine because of the training we get in internal medicine really fits very well in the day-to-day practice, especially outpatient practice of medicine. Do you see any trends in encouraging younger folks to do HIV medicine with an internal medicine background, not necessarily specializing in infectious diseases or some other primary HIV specialty?
Well, one of the reasons we have this guidance is to make HIV care more digestible for people who aren't primarily HIV care experts. So we really do want to encourage people to engage in taking care of people with HIV. If they are in a primary care setting, they're not necessarily infectious diseases. But I don't want to let infectious disease doctors off the hook
Mhm.
because there are a lot of infectious disease docs who could be taking care of people with HIV, but actually maybe aren't getting as much exposure and as much training as they need either. Now, we're really going to need all hands on deck. Our workforce has really taken a hit, particularly during COVID. The HIV workforce is totally insufficient to take care of the number of people that we have living with HIV. And we're doing a good job in helping to keep people alive. But unfortunately, people are continuing to acquire the infection. So we need all hands on deck. And I think we really do have an opportunity for people who are in primary care and aren't focusing on HIV to begin to learn some good old basic HIV medicine. And it is so much simpler these days. Our drugs are simpler, the side effects are much reduced. And many people are very stable over decades. I mean, I'm having 30th anniversaries with my
Mhm.
patients, and that's very gratifying. One of them said, if I thought I would be alive for so long, I would have moisturized. But, I think it is a different world than we had. And so, I really do want to encourage us to work with medical students to be sure our curricula include HIV medicine. And for medical students, for internal medicine, but also for infectious diseases, to be sure that infectious diseases doesn't leave HIV behind. And there also are some targeted experiences that the HIV Medicine Association has supported in the past to give non-HIV clinicians an intensive look into working in an HIV clinic so that you can learn HIV medicine. So I think there are lots of routes to get here, but I do think we are going to need to expand our workforce dramatically to take care of people.
Very well stated. I don't have anything to add to that. That was spot on. And unfortunately, we're out of time, but I just want to say that you are a shining example of how to do it, how to be an HIV uh, internist who focuses on this population, broad scope of all the nuances of meeting the patient where they are, not just physically, but also emotionally and otherwise, providing that support. And your career is a real testimony to the joy of providing care to HIV patients, and especially the joy now of the longitudinal experience. Some people, especially those maybe who went into infectious diseases, you might do a consult or see the patient for 3 or 4 days, maybe one time in follow up. With HIV, you get this longitudinal experience, and it's very rich. And you are a shining example of how that can be done well. Thank you for joining us today. Thank you for going over the guidance. Obviously, people should go to the clinical infectious disease website, or you can just Google primary care guidelines. Came out in December of 2024. As you mentioned, the article is free, so I encourage everybody to look at that. And thanks again, Melanie, for a great podcast with us today.
Well, thank you, Mike. It's been a pleasure to be your colleague and your friend for so many years. So thanks for doing this super podcast series.
Okay. Thank you. Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.